Well, welcome everybody. I'd like to welcome you to the second session of our Trauma-Informed Care series. Licking Knox Trauma-Informed Care Leadership Committee welcomes you all, and this is a six-part series. The first session is available. We recorded it. You can find it on lcfamilies.org. Some of our partners may have posted it on their websites as well. So we'll get started here in a second, as we only have a half an hour for the presentation. It'll be followed by an optional 15 minutes of questions and answers with the presenter. We ask you to please complete the evaluation at the end of the session to let us know how we're doing and if there's any additional information or training that you would like. While we're unable to offer CEUs due to the short length of each session, we will offer a certificate of attendance for those who are interested. Please include your name on the evaluation. I haven't sent that out from the first session, but I'll be getting that out soon. These sessions, like I said, are being recorded. The recording is already turned on. And then those who can't join us can take part in that and catch up and hopefully join us with the third session. We'll also offer resource information, handouts, and PowerPoints to the attendees. As we work those details out, we'll get that information to you. And we hope you enjoy and benefit from the session today. And I'd like to thank the committee for putting this series together and welcome our presenter, Peg Tazewell, who will introduce herself.
Okay, good morning. Can everybody see the screen with the recognizing trauma on it?
Yep.
Okay, awesome. So my name is Peg Tazewell. I'm the director of Knox County Head Start. I've been with my agency for more than 25 years and been director for 22 years and have been kind of immersed in the work of trauma and the adverse childhood experiences study, which I'm going to speak to directly today, for about the last, I would say, 13 to 14 years. So it is a little bit of a passion of mine, and I'm going to try to fit as much as possible into this presentation, and I will share the PDF when I'm finished. When people log in late, they miss what has previously been posted, so I'll wait a little bit. So I am going to start by refreshing some of the things we learned from session one. So first, the definition of trauma that Tamara gave to us, which is individual trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that may have lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And I think what Tamara pointed out was that it's something experienced by an individual. One of the things we know about trauma is not everyone experiences it or reacts to it in the same way. And that's really important for us always to remember. And our whole point of this series of sessions is to try to have us think about trauma-informed care and what is important about trauma-informed care. So again, using that definition, it's an approach that's focused on an understanding of and responsiveness to the impact of trauma. That's for individuals. That's how it impacts our community. And ultimately, we are working to promote positive outcomes by emphasizing physical, psychological, and emotional safety, and enhancing well-being by empowering individuals to define their own needs and goals and to be able to make choices about their care and their services. One of the things that was shared with you were the 4 R's of trauma-informed care: to realize what trauma is and what the impact can be, to recognize trauma, to respond, and to resist traumatization. And I share this again just to identify that today we are focusing very much on recognizing trauma, the signs and symptoms of trauma, which may be behavioral, emotional. There will be health impacts as well. And how it in fact impacts individuals and others. So we're going to talk first about the roots of trauma, and I'm going to speak specifically to the adverse childhood experiences study. Much of what we know about trauma, much of the research of trauma, was kicked off with the results of this study in the late 90s. So first, to define adverse childhood experiences, or what we'll refer to as ACEs, they are potentially traumatic events that occur in childhood before the age of 18. And again, I say specifically potentially, because not every individual responds to trauma in the same way. And we don't really know enough about why trauma may impact some folks very significantly and may not impact others. It is some of the areas of research, and in the weeks to come, we're going to talk about building resilience as a way to address the impact of trauma specifically. So the Adverse Childhood Experiences Study was a collaboration between Dr. Vincent Folletti with Kaiser Permanente Medical Care Program in Southern California, and Dr. Robert Anda, who was a researcher at the CDC. And I see I missed a T at the end of his name. My apologies. It took over 17,000 individuals who had Kaiser health insurance. It was in 95 to 97. I actually had Kaiser health insurance in Southern California up to 1994, and it was really a gold level health insurance. So these were primarily working adults with this health insurance, and during physical exams, they used a survey to provide detailed information about each individual's childhood experiences of abuse, neglect, and family dysfunction. So when you think about the population of this study, you know, this was not necessarily the population that we would serve, for instance, in our Head Start program. This was not primarily a population of folks without resources. These were working adults with very good health insurance. The ACE study is really considered a landmark in epidemiological research that recognizes the occurrence of adverse childhood experiences and their impact across the lifespan. And it's really important to note the study's findings have been replicated across populations and with similar outcomes in states throughout the US, and even throughout the world. This study has been replicated. And the results really are similar or sometimes more significant in terms of the impact of ACEs. So adverse childhood experiences specifically fall into three areas, and those areas are abuse, neglect, and household dysfunction. So when you think about the categories of abuse, we're talking about recurrent physical abuse, recurrent severe emotional abuse, contact sexual abuse. We could be talking about physical neglect or emotional neglect. Again, these are things that occur before the age of 18. And then some household dysfunction areas, you know, violence, and specifically witnessing a mother or mother figure being treated violently, substance use and abuse, so that might be alcohol or drug use and abuse, mental health concerns, living with someone in the household who is chronically depressed, mentally ill, or suicidal, where at least one biological parent was lost to the patient during childhood, regardless of cause. So that could be separation or divorce, but it could also be death or desertion. So it, you know, it may not be something, you know, we have to keep in mind that the death of a parent during childhood is going to have an adverse experience on children. And finally, household incarceration of someone in the household is one of the original 10 adverse childhood experiences. So there were a couple of significant findings in the research. The two most important findings that surprised the researchers are that ACEs are much more common than recognized or acknowledged, And that importantly, they have a very powerful relation to adult health 50 years later. And really, I would say 20, 30, 40, 50, 60 years later. Um, Inequity, and this is something Tamara mentioned last week as well, inequity does have an impact on the incidence of trauma, both how often exposure occurs and the resilience factors that might offer a buffer to trauma. And exposure to trauma is especially common among individuals with mental illness, substance use disorders, and developmental disabilities. So the ACEs study indicates that adverse childhood experiences are the most basic and long-lasting cause of health risk behaviors, mental illness, social malfunction, disease, disability, death, and healthcare costs. And I was able to see Dr. Folletti speak many years ago, actually in Columbus. And one of the things he identified was that when he did not believe these results at first, he went back over and over again to check them. And when he finally accepted them, he stated that he wept because he could see that there was so much happening that really societally would be under our control, and really areas that we should be able to address and improve. There was some additional, one of the areas that replicated, one of the locations that did significant research on the adverse childhood experiences study was in Philadelphia, which is my hometown. So they did a major Philadelphia ACEs project, and they broadened in the initial 10 ACEs to add some community level ACEs that came out of their study. That included racism, witnessing violence within a community, growing up in unsafe housing and neighborhoods, bullying, and growing up in foster care as a potential ACE for children. And what their research identified was that the more limited set of ACEs substantially underestimates the prevalence of potentially traumatic experiences. And the results of the study showed that 70% of the respondents had at least one adverse childhood experience, and that's compared to 64% in the original study, and 40% had 4 or more adverse childhood experiences, and that was compared to 13% in the original study. This is a map that we used a number of years ago in some community training that we did. And it was from the National Survey of Children's Health in 2011 and 2012, which estimated that 22.6% of children in the US had experienced 2 or more adverse childhood experiences. And the color key in this shows that the Rust Belt in red, so beginning with portions of Michigan, Indiana, Ohio, West Virginia, Kentucky, Tennessee, down into Louisiana and Alabama, show significantly higher experiences of adverse childhood experience. And that was replicated in some Ohio research that was done as well. I couldn't find a new map. I found a lot of maps that sort of identified the percentage of children with 1 ACE and 2 and 3 and 4, but that was many too maps to show. So I am going to share at the end my email address. I have way too much of this information stored in my brain and on my computer, and I'm happy to share if anyone is interested. But for us in the world of Head Start in particular, and I know we have a lot of educators with us today and folks who work with young children, it is really important for us to understand the impact of ACEs, or the potential impact of ACEs on kids, and to be aware of how prevalent it is, and that it is more prevalent here in the state of Ohio. And my experience working with populations with limited resources in the area of Head Start shows that our children show a higher incident of adverse childhood experiences than the general population. So I would add, in addition to things like racism and growing up in neighborhoods that are unsafe, I would add poverty as well. Growing up without meeting basic needs, we see as an adverse childhood experience. And this is the famous pyramid that came out of the adverse childhood experiences research to kind of show the mechanism that impact the health of those individuals who do experience the negative impacts of ACEs. So, what we see is disrupted neurodevelopment. So, what we say in our work is that children's brains and bodies are not wired for good health and success when they experience chronic trauma. That it really rewires the brain to have a kind of a stress response that we'll talk about a little bit later and that Tamara talked about last week. So you end up with disrupted neurodevelopment. It does impact then educational outcomes. It can reduce educational outcomes and impact social, emotional, and cognitive development, specifically in the frontal lobe of the brain. That area may be smaller when there have been impacts of multiple adverse childhood experiences, impacting executive functioning within the language of education. Individuals, they then may have behavioral health concerns. They may adopt health risk behaviors, including smoking, substance use and abuse, alcohol and drug use. There may be chronic mental health issues that include depression, more likelihood of depression, more likelihood of attempted suicide. There then can also be a significant rise in chronic health conditions, including things like sexually transmitted disease, liver disease, COPD, ischemic heart disease, autoimmune disorders, and cancer. And ultimately, that impacts disease, disability, and social problems, which leads to early death. And one of the heart-stopping for me impacts of ACEs is that individuals with 4 or more ACEs, some research shows they have less than a 3% chance of living to age 65. So the range, the results of the research show that there can be a loss of anywhere from 10 to 15 years in expected lifespan. Okay, so that's the adverse childhood experiences study. And we're going to shift a little bit into some of the ways that we can recognize trauma. The first part, I think, is learning about individuals and their experiences. Obviously in therapeutic conditions, hopefully you're going to get to the point that you will learn about folks' experiences in childhood and try to discern if any of those experiences may have affected the current circumstances of an individual. For young children, the hard thing for us is that our babies and toddlers and preschoolers have limited verbal capacity to share with us what's going on with them. We have to rely on learning from parents the experience of children, and it really might take time to build a trusting relationship with parents before you'll learn about all of the experiences a family member has dealt with in terms of exposure to trauma. So we might observe in children and adults the physical and behavioral responses and patterns they have, specifically to situations of stress, but not always. And this is really hard work. We have to discern. It's easy to come out of learning about ACEs and learning about trauma and begin to see it everywhere. And we have to be a little bit careful of that. Because we do have to be aware of what is developmentally appropriate for various populations and across the lifespan. So what is developmentally appropriate for young children what is developmentally appropriate for elementary age, middle school, adolescents, and also adults across their lifespan. And what we always say in our work is that we always have to assume the presence of trauma. So we just kind of assume it across the board that both the children that we serve, the parents that we serve, and our employees, our colleagues, the people we work with, we assume some exposure to trauma. And then that kind of lays the groundwork for why trauma-informed care is critically important, because we do see it as a universal precaution in terms of how we approach everyone that we serve and the need to create trauma-informed environments.
We
So
have
I'm
10
going to talk.
minutes.
I'm sorry, Sylvia, do you
10,
have a question?
10 minutes.
Okay, thank you. 6 slides. I'm going to talk about the physical impact of trauma exposure for children, and you're going to see similarities between children and adults. So children may have, in reaction to an experience, heart pounding. You may see children who are prone to stomach aches and headaches, generally feeling unwell, more prone to vomiting, loss of bladder or bowel control, and changes to habits. And, again, for young children, I would say up to age 8, we tend to look closely at where we've seen changes to habits or to skills that children already have and seem to regress within. You may see changes in eating habits or loss of appetite, sleep disorders, nightmares, difficulty sleeping. In a full day, full year environment where we have Head Start and childcare services, we nap because it's a 10-hour day. And you may see children who do not feel safe enough to rest, who do not feel able to lie down and sleep and really resist that. You will see hypervigilance and behaviorally we'll see some relationship to extreme behaviors, a very exaggerated startle response, trouble concentrating, depressive symptoms, and low energy level. In adults, you might see some acute symptoms, and again, these are similar. Increased heart rate, sweating, trembling, muscle tension, nausea, pain with back, joints, headaches, trouble breathing, and dizziness, and then some chronic symptoms that we'll see with adults especially who've experienced adverse childhood experiences, but also in adulthood who might have extensive exposure to chronic trauma. And that might be things like high blood pressure, high cholesterol, obesity, heart disease, chronic pain, fatigue, and decreased life expectancy. So trauma can impact children's behavior. And again, when we talk about children, behavioral health, it's all kind of integrated. So some of these relate to the health issues. Children may have difficulty regulating their emotions and behaviors, may have very limited impulse control, may lack the ability to think through the consequences. Again, if the executive function is not developed, there can be real difficulty in planning. Children may experience extremes of behavior beyond what is developmentally appropriate, and that can be across the spectrum. So it might be intense and ongoing fear, sadness, or anxiety. It might be extreme irritability, anger, or aggressive behaviors, and it might be attachment behaviors, real clingy, fearful, or difficult to control emotions. Again, trouble sleeping and nightmares. That behavior is going to relate to health issues, it's going to relate to cognitive issues, and it's going to relate to the behavioral issues in a classroom. You may see difficulty with basic skills and loss of recently acquired developmental skills. Thoughts or memories associated with trauma may trigger a strong emotional or behavioral reaction. And I think the hardest thing that we see in young children is young children may misunderstand the events of the trauma and believe it is their fault. And that may come out. We partner with the Village Network in providing play therapy to children. That may come out in the course of therapy. Similar things with children. Adults may be more prone to arousal and reactivity irritability and aggression, risky behavior, avoidance of certain issues and circumstances, getting stuck in negative thinking patterns, having memory patterns, physical arousal, emotional numbness, and feeling detached. So all of these exposures to trauma may play out in how adults behave. Again, revisiting the trauma responses that were reviewed in the last section, we're looking at flight, fight, freeze, and fawn. And some of the ways these play out in flight is, we call them elopers. There may be running away, avoidance and withdrawal. In a freeze response, there may be an inability to make decisions, avoiding circumstances, or numbing with substances. In a fight response, there may be this extreme impulsive behavior and aggression, reactiveness and defensiveness. And then in a fawning response, we may see lack of boundaries, people pleasing, codependence, and low self-esteem in the individuals that we serve. And as we spoke about in the last session, the guiding perspective that we desperately need in our entire society, but especially in education and health and behavioral health, is really to put those trauma glasses on and to begin to ask what happened to you of folks and not what is wrong with you. To really shift our lens, to shift the perspective by which we see individuals that we serve. Again, this is a repetition from our last presentation, to be aware that anyone can experience trauma. It is not a sign of weakness. Inequity does impact trauma. A supportive environment is crucial for trauma recovery. Trauma does manifest differently for different people, and symptoms really do not go away, but they are treatable. So what's next for us to think about? You know, there's two primary areas that we're looking at. We're looking at intervention, and for us, both in looking in Knox, increasing access to treatment, developing and maintaining trauma-informed care strategies and environments. And the next four sessions are going to go specifically into how we can do that. And in the work that we do, especially in early childhood, finding ways to prevent trauma. And I've shared with you a screen or an image, and it's from 2014 from the website ACEs Connection. And this used some research to estimate how much we could reduce exposure to these areas if we reduced ACEs. So we could make transformative impacts to our society if we could find preventive ways to reduce adverse childhood experiences. I've listed the next upcoming sessions in the Trauma-Informed Care Lunch and Learn series. And this is really hard stuff. It you know, emotionally can be draining to me when we think about this work, but we're going to transition in the next session to building on strengths and promoting resiliencies. So this is how we flip the story. This is how we begin to write a new story for the individuals we serve by identifying strengths and promoting resiliency. That is on October 8th, and I've listed the additional sessions as well. So questions, comments? I'm going to pop this into the chat so you can have a PDF of the PowerPoint, and my email address is on there as well. With 1 minute to spare.
That was amazing.
That was a lot. All right, let's see if I can put this in. Does anybody have any questions? Like more information?
Peg, are there any trends that you see with very young children, like some of the most common behaviors that you might see? You learn that they have experienced trauma, and am I making sense?
So, you know, unfortunately, we are seeing a really a real increase in parental stress and seeing it play out with young children. And really seeing kids as young as 2 with rage. You know, it used to be when I started this work back in 1999, we might have 1 or 2 children in a classroom who are really struggling to become regulated and to know how to manage their emotions. And now, you know, we have classrooms where there's 6 or 7 children with really severe behaviors. And we've definitely seen, you know, in kind of the unwinding of the supports that were in place during the pandemic. They were so helpful and they mitigated so many challenges for us. But the loss of the child tax credit, the loss of the expanded SNAP benefits, the loss of housing protections, and now we're seeing adults losing access to health insurance, like all of that. And then, of course, the recession that we're seeing, well, some of the recessive traits in our economy and the higher prices. You know, it's really just causing stress levels to rise. And we're seeing a lot more rage, a little bit more withdrawal, not as much increase in children's withdrawal symptoms in the early child population. We're seeing more rage. And that can be very, very difficult in classrooms to navigate and for parents to navigate. You know, the hardest thing that we see when you dig into this work is that this is a cycle. You know, there's a whole part of the research on the transgenerational transmission of trauma. There was not time to go into that today, but sometimes switches are flipped in DNA that make folks more prone to the impact of trauma. That's some of the theory about why one individual may not have a negative outcome and another individual might, if there is an intergenerational and transgenerational transmission of trauma. Sorry, I don't know that I answered your question.
Yes, thank you. Anyone else, please feel free to ask your questions.
We may want to stop the recording if you haven't done that. I don't know if I can do that.
Hi, Sylvia. This is Katie Burkhardt. I'm on audio on my phone. I can't get to the chat. Is there any way I can get the slides?
Yes, Peg's, yeah, she sent them and we'll get them out to the group.
Okay, great. Thank you.
Do we have to give information about a survey on the back end, Sylvia?
Yeah, I think when we're finished, then Lynn will get that survey out to folks. If there's no more questions, then I guess we'll move on to that.
You know,
Thank
and
you
just
so much.
to remind folks to please complete the survey, and especially, you know, when the Trauma-Informed Care Committee gets through this series of first 6 sessions, certainly we'll look back at what people need more information on, what areas might interest us as we move into the future. Thank you for your time.
Thank you, Peg. Have a nice day, everybody.
Bye.